Yes, good morning, everybody. Just put my presentation. Let me see, where is it going in? I always have problem to put that into a form that is activated in Diaporama, but
Michel, dans le bas de ton écran, là, complètement
yeah, it's down, but I cannot do it. So anyway, I'll just go back and stop the sharing, and I'll tell you what it is about. Anyway, it's great, and I dress up for the event. This is Journée Mondiale de la Vasectomie, and I've got my cup this morning with all the lurking sperm. So thank you for attending, everybody. We're 170 person attending. And actually, as the introduction, I had a few slides showing that I wish all my patients would be dogs, because we wouldn't be here this morning if our patient would be dogs, because dogs don't have seminal vesicule, and they do one ejaculation, two ejaculation, and it's done. They're already sterile. In human, our anatomy is more complex, and unfortunately, we don't know if it's coming from the testicle, from this complex structure. So today we're gonna have all those speakers telling us how to make it simpler, more clear about this lurking sperm, and hopefully at the end of the session we'll know more about it. And I will introduce our first speaker. First speaker is Dr. Jay Sandlow. And Dr. Sandlow is professor and chair of the Department of Urology at the Medical College of Wisconsin in Milwaukee. He is also the director of the Male Infertility Andrology Fellowship of his university. I will not go through all his publication and research project for the sake of time. It would take the whole hour. I need, however, to mention his significant contribution to our knowledge on vasectomy. He has been a member of the committee of the American Urological Association Vasectomy Guideline. He was also invited as a guest editor for Urologic Clinics of North America on vasectomy and vasectomy reversal. Jay, it's a great pleasure and an honor to have you as our keynote speaker this morning.
Thank you, Michelle. It's great to see you and to meet everybody. And just a little bit of background, Michelle and I, we've known of each other for a long time, but we finally met in person when we were on the AUA vasectomy guidelines panel. And as we'll go through some of these guidelines, you'll see that much of this comes not just from Michelle's advice, but from all of his publications. I don't know that I've ever seen anyone publish more on vasectomies than Michelle. It is amazing. You can't think of any topic that includes vasectomy that doesn't have at least one or two papers from Michelle. So thank you. All right, I'm going to try to share my screen here. And this is where I work. So good morning for people that are in North America. Good afternoon for people in Europe, and probably good late afternoon, evening for people that are in Africa and in the Middle East. We're going to talk about post-vasectomy semen analysis, the hows and whys. And I do want to say that there will be some trade names of commercially available items. I need to mention them, but I'm not meaning this as an endorsement of them. So I know that many of you have probably had patients ask about minimally invasive vasectomies. I always get questions about, Doc, I heard there's a laser vasectomy. So I usually show them this picture and that ends that conversation. So what are we going to talk about this morning? One, I think we need to understand the concept of the post-vasectomy semen analysis, or PVSA. Also, we need to look at the different options that are now available for doing PVSAs. And then importantly, we're going to compare the recommendations of vasectomy guidelines regarding PVSA from both North America and European societies. So a little bit of background, as I mentioned, about the AUA guidelines. This was a panel that was put together back in 2009, and ultimately we published the guidelines in 2012. We had to review literally hundreds of abstracts and studies. And when it comes to PVSA, what we determined was that azoospermia and rare non-motile sperm, and that was defined as less than 100,000 sperm per ml, were considered adequate for sterility. There was great data that we're going to go through some of these just to show that even these patients who have, as Michelle calls them, the rare lurking sperm, are considered sterile. So one of the things that we need to understand is that the occlusion technique really plays a lot into the role of PVSA. So if you do a really good occlusion technique, you could almost make the case that you don't need a PVSA, and we'll talk about that a little bit. If you look at these were the occlusion techniques that we found were the most effective, and if you look at the failure rate, we're talking about 0.5% or less. For sometimes some of these studies were nearly 50,000 people. So we've got extremely good evidence that if you do a vasectomy using the recommended techniques, PVSA may actually not even be all that important. This is a study that Mark Barone did back in the early 2000s that shows the disappearance of sperm, and this after a vasectomy. And this is where we get the time course of when we would check our PVSAs. So the green and blue bars are basically men who we would consider sterile. Green are the azoospermics, and these blue bars are the less than 100,000 non-motile sperm. And you could see that by 12 weeks, 96% of patients would be considered sterile. So that's where we got the recommendations of 8 to 12 weeks to determine sterility. So, as I mentioned, why do we even do PVSAs? What are the pros of doing them? Well, we can confirm our occlusive success. That's the biggest one, is to be able to reassure our patients that, yes, your vasectomy was technically successful. We can reassure the patient, and more importantly, reassure the doctor. I think particularly here in the United States, we are very nervous about legal issues, and so we consider the PVSA as much medical legal protection as we do just good patient care. But what are the cons for doing a PVSA? As I mentioned, if you do a vasectomy correctly, we have a very low baseline failure rate. So if you think about a vasectomy as a screening, or a PVSA as a screening test, you're looking at something that, if done correctly, the prevalence of failure is already very low. It's definitely inconvenient. Patients have to collect a sample, they have to drop it off somewhere, or they have to mail it. And there is a cost involved. And I think particularly in these days of cost containment, we need to be very aware of the fact that post-vasectomy semen analyses for some people are not cheap. So let's look at why do vasectomies fail. I briefly mentioned how we do the vasectomies that tend not to fail. So why do they fail? Technical error. So there are many people who are using outdated methods that have high failure rates, and I didn't go through those, but there are some methods that have failure rates that are as high as 5 to 10%. I've certainly seen patients who have had the same VAS divided twice, where the provider just missed the side. And very, very rarely, and I know this comes up a lot, and on the Vasectomy Network, we talk about it all the time, but there is a very rare condition where you could have a true duplication of the vas deferens. I personally have never seen one that's been documented, but I know that there are some case reports where they actually do have both pictures and pathology that shows that there was some vas duplication. This is super rare, and yet this is probably one of the most common reasons that I get patients referred to me for repeat vasectomies. Their physician told them, you must have a duplication because I did your vasectomy and it failed. And actually, that's probably not the reason. It was probably for one of these top two reasons. Then there's something called recannulization. There's two different types of recannulization. There's what we call early recannulization, which is recannulization that happens within the first 4 to 6 weeks. And I'm going to go through a chart in a second. And that is not super uncommon. I would say that I quote my patients less than 1 in 5 to 600, but typically we will see this even if you do the vasectomy exactly as you should. And then there's late recannulization. Late recannulization is when somebody has been confirmed to be sterile, and then somewhere down the road, they've got sperm back in their semen. They may not necessarily have a pregnancy, although most of the time that's what stimulates another semen analysis. But we do have some patients who like to be reassured every couple of years. We quote late recannulization rates as about 1 in 2,000. I think most of us that do a lot of vasectomies know that that's probably lower than that even. So, of course, this is a paper by Michelle that looks at the different types of early recannulization. So if you look at patient number 5 here, so the circles, starts out with a very high sperm count. At 2 weeks, he's already 0. So if you had a patient who dropped off a sample at 2 weeks, and once in a while I do get these guys who read on the internet, I read that if I ejaculate 20 or 30 times, I should be sterile, and they bring their sample back after a couple of weeks. This man would have been declared sterile. But look, at 6 weeks, he's back up to where he was. Now, he subsequently went back down to 0 and stayed at 0. So this would be called a subclinical early recannulization, because we would not have even checked him until 8 to 12 weeks. If we checked him at 12 weeks, we would have said he was sterile. If we checked him at 8 weeks, we would have said, he still has some sperm, but when we recheck, he would be at 0. So this is a successful vasectomy. Let's compare that to patient number 8, who patient number 8 starts out up here and then goes to 0 at 2 weeks. But then at 8 weeks, he's back up into the millions, and that's where he stays. So this is a persistent early recannulization. We call that occlusive failure. This is someone who ultimately will need a repeat vasectomy. This is rare, but it happens. So now let's talk about PVSA compliance, because as most of you know, men are fairly non-compliant. We don't like to follow directions. We don't read instructions. And so what is it about us that we just don't follow up? Arnold Belker back in early 1990s found that 36% of his patients never even came back for their first PVSA. And back then, when we needed 2 azospermic samples to be declared sterile, only 54% of his patients came back for that. There was a more recent study out of the Cleveland Clinic that looked at the impact of making an actual appointment for the patient to drop off a sample versus the patient just doing it. And they found a huge increase in compliance if the office made the appointment on their way out. And then this interesting study recently showed that home testing, which we would all assume would make compliance better because guys would be more likely to do it, showed that even in men who opted for at-home testing, there was no difference in how many actually followed up. We'll talk about that in a little bit because I think this paper may be a little bit of an outlier. So what are the controversies about PVSA? Well, first of all, when should we do the first one? I think that was well answered with Michelle's study, that we don't want to do them before 8 weeks because we will overdiagnose early recannulization. How many should be done? I think there are great studies out there that show that if you have one sample that's azoospermic or rare non-modal sperm, that patient is sterile and you don't need to do repeated samples. And then what's the criteria for success versus failure? And when we talk about success and failure, we're talking about occlusion success or failure, not pregnancy, because those are different. How should the sample be delivered? So we've always insisted on fresh specimens, which is not very convenient for a lot of people. In other countries, mail-in specimens have been done for a long time, and we'll talk about the pros and cons of doing those. And now there are also some home test kits that you can buy where you can do it at home. And then finally, how should the samples be analyzed? So this was actually a bigger deal than I thought. I kind of figured, well, you just look at the sample and you see. But when we came up with our guidelines, we send these guidelines out to probably 50 or 60 reviewers, some of whom were lab people. And the comments that came back were really variable. And so, we wanted to know, well, how much do you need to examine of a sample? How many high power fields should you examine? And really importantly, and we'll talk about this in a little bit, should you centrifuge or spin the sample to look for those lurking sperm? So here are the three options for PVSA. You can do a fresh sample. You can either drop it off at a lab or at the physician's office, and then the physician can look at it. You can mail in a specimen, so that can be done through your doctor's office, or now there are online kits that will send you a kit, and then you can send it back to them. And there are over-the-counter at-home kits. Right now, there's just the sperm check, and we'll talk about sperm check in a bit. So I just wanted to go a little bit into my practice. I have about 6 different labs throughout the city that patients can drop samples off to try to make it more convenient for them. And these are just our general hospital labs. But I did standardize their techniques so they know not to centrifuge samples. They know how many high power fields they need to scan. And they basically report azoospermia, 0 to 2 non-modal sperm, which we've calculated to be less than 100,000, or more than that. And anything more than that, we don't consider a success. But we also have our andrology lab, which is where we do our fertility testing. And so these are, dedicated andrologists that, they find sperm in testicular tissue in men who have testicular failure. So they can find one sperm, they can find the literal needle in the haystack. What they do is they use 3 microliters, not 3 milliliters. 3 microliters on a microcell. They scan this entire microcell with 200x. And if they see any sperm, then they can report that as a concentration. If that concentration is greater than 100,000 per ml, they will actually do a full semen analysis. Otherwise, what they put in the report is less than 100,000 per ml, and then they just tell us how many sperm and whether or not any of them are moving. And I think Michelle's lab is fairly similar. I think they use 5 microliters. A lot of people scan with 400x for high and do 50 high power fields. I think the bottom line is, however your lab does it, need to make sure that if they are finding sperm, that they can report a concentration. So let's look at these mail-in tests. There are 3 commercially available mail-in tests in the United States right now: Fellow, Mail from Home, and PVSA. And I'm not going to go into details. I think Don Snyder, when he speaks after me, will be going into more of the details of these. It's important to know that these are all CLIA-approved labs, but they cannot detect motility. So basically, all they can tell us is, are there sperm? Are there no sperm? If there are sperm, they can give us a concentration, but they can't tell us whether or not they're motile. And then the over-the-counter home testing right now, that Sperm Check is the only one commercially available in the U.S. It can detect down to 250,000 sperm per ml with 96% accuracy. So fairly good testing. Very importantly, high positive and negative predictive values. And really important, consumers are actually able to use it. It doesn't do any good to have a test if the consumer can't use it correctly. 97% of men were able to use it. Again, it does not detect any motility. And unfortunately, it can't distinguish between 0 and 250,000 sperm per ml. So by our criteria in the AUA guidelines, we could not recommend home testing as being enough to determine sterility, only because of this 250,000. However, if you make it easy for patients, that may improve compliance. And again, when you're talking about a procedure that has such a low success rate, maybe we really do need to extend that upper limit to 250,000 because we have such a low failure rate to begin with. So now let's look at the differences between some of the guidelines. These are guidelines through both European and North American societies. Interestingly, if you look, the timing of the first PVSA is fairly standard. It's about 3 months. In the AUA guidelines, we said between 2 and 4 months. Some of the societies actually also suggested how many ejaculations. We do know that about 20 to 25 ejaculations will typically clear out the remaining sperm, but that in and of itself is not adequate. I had one of my patients give me the best analogy for why you need to do these ejaculations after it. He was a plumber, and he said, if you think about it, when you turn the water main off to your house, you still have to run all the faucets to empty the pipes. And that's exactly the same thing that happens with the vasectomy. You occlude the vas deferens, but you still have all those sperm on the other side that need to be cleared out. And then, as Michelle mentioned, in the human, between the ampulla of the vas deferens and the seminal vesicles, you've got all these little nooks and crannies where sperm can hide. And while most of them will be dead, they can show up for years later. Looking at the actual semen samples, all of the societies recommend a fresh sample, but interestingly, there are 2 that actually recommend centrifuge samples. And the problem with that is that there's some pretty good data that shows that if you centrifuge samples in men who are actually declared sterile, you will find some sperm. Not enough to exceed the 100,000 per ml concentration, but you will find sperm. There was a paper back in the 90s that was done out of Cornell where men who were coming in for a vasectomy reversal, so these were all men who were considered sterile, and 15% of them had sperm in their centrifuge semen samples. So we were very clear when we came up with the guidelines not to centrifuge because all you're going to do is confuse people. Several of the societies, and particularly in the UK, are either accept or recommend mail-in samples. But the self-testing, really there isn't enough data yet. to be able to recommend that patients can be cleared just on that. This, I think, is a very important slide because for years and years, men were giving multiple samples because they were getting rare non-motile sperm, and the physicians were saying, well, I'm not comfortable in clearing you, so you're going to have to keep coming back until you are zero. And for a long time, for instance, in the UK, they had the quote special clearance, which were men who had less than 100,000 non-motile sperm. And what we found is that those men have no higher failure rate than men who are azoospermic. And once you are azoospermic or have rare non-motile sperm, you're done. You don't need a second sample. Everyone agrees with that, although interestingly, the Canadians say that you probably need, you may need a second sample if you have rare non-motile sperm. And the same thing in the UK, you may need a second sample. I will say that my first vasectomy that I did, and this would have been back in the 90s before we had any of this data. And of course it was on a physician, because that's where all bad things happen, is when you operate on another doctor. He had rare non-motile sperm, but back then I didn't know that was okay. I probably had him come back monthly for 6 months, still had rare non-motile sperm. I said, wow, I think you're sterile, but I can't guarantee it. And he made me do another vasectomy on him. Guess what? Still had rare non-motile sperm. So I was able to reassure him that we did not need to keep going. And actually, that's part of what spurred my interest in all of these guidelines, because when I looked for advice, nobody had any really good advice for me. I didn't know Michel back then. He probably would have told me he was sterile the first time. And then looking at failures, how do we define a failure? Basically, any motile sperm after 6 months, most of the societies agree that is considered a failure. But many of them also have the physician make a judgment. If you have greater than 100,000 non-motile sperm after 6 months, it's up to you and the patient to sort of decide, how comfortable are you with this? Is this a recannulization, or is this just residual sperm that are lurking? And more importantly, if this is recannulization, but it just remains as very low numbers of non-motile sperm, is that patient still sterile? Like, what are the chances of them achieving a pregnancy? It's extremely low. And so does the patient really need to go through another procedure? So looking at our AUA guidelines, after all of the data that we reviewed, we found that once you had azoospermia or rare non-motile sperm, patients could stop using other methods of contraception. But this was in an uncentrifuged fresh sample. We also found that 8 to 16 weeks after vasectomy is the appropriate time range. As you saw from other societies, around 12 weeks. And I tell patients, if you are sort of in a hurry, you want to get your partner off of birth control, if you ejaculate frequently, you can certainly test at 8 weeks. And if you're zero, you're zero. And then finally, we determined, and there wasn't great data on this, so this was more expert opinion, but if there were any motile sperm after 6 months, then you should consider repeating the vasectomy. So let's look at some practical principles. Again, remember, we're dealing with men. So we need to make the PVSA protocol as simple as possible. If it's complex, men won't do it. We want to allow for confirmation as soon as possible, but we also want to minimize how many samples they need to drop off. So when I'm counseling my patients, I say, well, listen, you can come back as early as 8 weeks, but your chance of having to drop off a second sample is certainly higher than if you wait 12 weeks. So The patient then has to decide which is more important, how long they have to continue to use contraception or how many samples do they want to drop off. And again, this is where things like the ease of getting the sample, the cost, those all are important. So if you had a very simple test that you could do at home to at least maybe get your first test, that is something maybe they could do at 8 weeks. And then if there's still sperm, they can drop a sample off at 12 weeks and know that they're probably okay. The protocol that's used for PVSA should confirm the effectiveness at the highest possible level of certainty. And I think we're going to hear a little bit about that later in terms of using some techniques that can basically give you almost 100% reassurance that at least at that point in time, your occlusive effectiveness was complete. And then finally, no matter what, you still have to inform your patients that post-vasectomy pregnancies are rare, but have been documented even if you have azoospermic samples. And there was a little exchange on the vasectomy Google network this morning about a couple in South America who successfully sued the physician for a post-vasectomy pregnancy. In North America, that would never fly. You know, it's considered a possible risk of the procedure, and as long as you followed the guidelines, and that's part of the reason we came up with the guidelines was to protect the physicians doing vasectomies. Patients would not be able to sue you for child support or malpractice. So I think that, you know, it's very important that patients understand that even if they follow all procedures and they're told that they're sterile, there's still a very rare chance. You know, DNA testing has shown that this does happen on very rare occasions where even if you are still considered azoospermic, that the child could be yours. I think Michelle calls it the ball valve, where you can have a little bit of an open and close where some sperm can sneak through and then it closes up again. It's obviously very difficult to catch that unless you are testing the patient, you know, on a weekly basis. So just to wrap up, most organizations, certainly in Europe and North America, would define a vasectomy success as azoospermia or less than 100,000 non-motile sperm per milliliter. Non-motile is very important. That means it has to be a fresh sample. There is some variation in the recommendations about mail-in testing, but I think that as these become better understood, we'll find that this may be another method that we can easily get patients to follow up, as well as some of these over-the-counter and online kits, which right now don't currently meet the threshold, but hopefully in the future we'll be able to rewrite some of our guidelines to do this. And then really the bottom line is, do we need a PVSA? I mean, if you think about it, as I said, at 12 weeks, 96% of patients are azoospermic. And we know that ultimately almost all of those men will become azoospermic. So I think here we're dealing with, this is as much a cultural thing as anything else. If you think about it, a woman has a tubal ligation, they don't do hysterossalpingograms anymore to determine that tubal ligation worked. And there's a much higher failure rate for tubals than there is for vasectomies. If you think about what other forms of contraception, what their failure rates are, and these are accepted. So oral contraceptives have a 3 to 5% failure rate if used correctly. Nobody gets crazy about a pregnancy after that. But if a guy has a vasectomy and he establishes a pregnancy, everybody goes nuts. I think a lot of that is because of our cultural and societal attitudes about male contribution to contraception, and I think that without getting, you know, too far down in the weeds. I think as men, we have to take responsibility that yes, we are part of contraception is our responsibility. And yes, there are going to be some failures. It's not the end of the world. So I'm really looking forward to, first of all, hearing from all the other speakers, but also seeing where we end up in the next 3 to 5 years in terms of a lot of these questions. This is just in some areas where vasectomies are not taught well. This is kind of the bargain basement vasectomy clinic. So again, I thank everyone for your attention. Thank you for inviting me to speak. And I'm really excited to hear not just the talks, but the discussions.
Thank you so much, Jay, for this super presentation. Actually, you really set the table, and thank you so much. There was a lot of comments, a lot of questions. Some will be answered in the subsequent presentation. I may have only one question that for you before we go on. Are there ways to be sure that there is no vas duplication?
Not as far as I mean, to me, the best way is you do your vasectomy and then you look at your PVSA. And if you did your vasectomy and your PVSA is negative, then there wasn't. That's the conversation though that I have with patients where I only feel one vas deferens, which is not uncommon. I know you've published on that, and we all have seen this where you clearly feel a vas deferens on one side and you really can't find one on the other side. And there's no good imaging issues. We talk about, well, you could get a renal ultrasound, and if they're missing a kidney, that kind of will confirm it. But many of those men do still have 2 kidneys. Those patients, I have a conversation. I say, look, we can do the side that's easy. And in 3 months, we're going to know whether or not there is another side. If you want, we can simply put you to sleep and explore you. But I will tell you, after having done probably 10,000 vasectomies, the likelihood that I can't find the vas on one side is pretty low. I won't say it's 0, but it's pretty low. And, I have not had a patient where that has occurred where we actually had a second side. There have been times where in the office I didn't feel the side, but when I went to do the vasectomy, I was actually able to find it. But if I can't find it, and this is what I tell all my residents, you do a lot of vasectomies, you know what a vas deferens feels like. So, but it's a conversation with the patient.
Very good. Yeah, I have the same experience. What about ultrasound to identify if there was a duplication?
Yeah. Scrotal ultrasound it's very difficult for them to even find a normal vas deferens on ultrasound. And so really, and I haven't seen any studies about something like MRI, whether that would or would not. But again, I also think we have to look at what's the prevalence of vas duplication, extremely low, and what is the harm. So if you or I do a vasectomy on someone who has a vas duplication that we don't catch, if he comes back, I know that that's something is not right there, right? And so that's when I would maybe start thinking about, could there be something different? Yeah.
And your ends will be the best diagnostic tool.
Yeah, absolutely.
Thank you very much, Jay. We'll go on. Our next speaker is Dr. Don Snyder. He's an obstetrician gynecologist by training, but a vasectomist by patient. He established his vasectomy-only clinic in Indianapolis in early 2000 and has performed over 6,000 minimally invasive vasectomies since then. He exceeded 1,000 procedures in 2022, and his practice continues to grow. Dr. Snyder has always performed his own post-vasectomy semen analysis. Don, please share with us your extensive and valuable expertise.
Okay, thank you. And thanks for having me. I'm going to, first of all, work on getting this screen share going. So sorry if there's some issues there. Let's see. Okay, we have that up and should be good to go. So thanks a lot for letting me be part of the webinar. I'm going to try to stay on script here for time, so I'm going to do a little reading too. So apologize for that. If I go too far off script, then 8 minutes will turn into 8 hours, and nobody wants that. So any PVSA that a provider doesn't do for their own patients really should be considered outsourced. So most of you already use a lab for PVSAs. So I'll only be discussing alternatives to using a lab because we're here to learn new things. I'll mention some specific options available for outsourcing PVSAs, the same ones that Jay did. And also I'm going to discuss how I do my testing. It's a little bit different, but it is insourcing. The kits for these first three companies, as Jay said, are generally purchased in advance and dispensed to patients at the time of vasectomy, and then the sample is produced at home and mailed from home after the clearing period. Fellow is a company that uses light microscopy on the sample, but it's diluted by a cryopreservative. The cryopreservative allows for motility to be seen, but really you cannot assess the accurate concentration. Mail from home uses mailed specimens, uses formaldehyde as a preservative, and so therefore it's diluted. And they use light microscopy, but also cannot be quantified if positive. PVSA.org uses a hemocytometer, and I know Matthew will be talking about that some, to count the sperm cells. So the testing could actually be really too sensitive and might result in a higher percent of positive tests compared to using light microscopy. And they only report, of course, whether sperm are present or not, again, because of the dilution. They don't know what the concentration is. Sperm check vasectomy, as mentioned, was approved in 2008. This is a chemical assay done by the patient at their home, much like a home pregnancy test, but again, can only give a yes or a no for the presence of sperm. And as mentioned, their cutoff is 250,000 and not 100,000. So in studies designed to find out why men didn't comply, inconvenience and embarrassment top the list on those. As Jay said, patients transporting their own samples are required to drive during business hours to the lab, which is really quite inconvenient. And then once they arrive, they're embarrassed. They're handing the specimen over to a person who knows exactly what they had just done within the last 2 hours, and that's very uncomfortable to a lot of men. Some couples are just plain ambivalent about the possibility of future pregnancy, or they trust the odds too much, and then certainly some people just forget. Melanie's going to be talking about her data about postal compliance soon. When I switched to using postal samples for my own PVSAs, patient compliance was not my primary motivation, but I found that I had an immediate noticeable increase in PVSA compliance. So let's discuss fresh versus postal samples a little bit. Fresh specimens allow for immediate clearance, as we mentioned, if the concentration is below 100,000 per ml and there are no motile sperm seen. But the trade-off is low compliance, as you're going to see more data on that. For postal samples, increased compliance is achieved, but some patients will need to wait for repeat testing in order to be cleared, because if there's sperm seen, motility cannot be assessed. So I find that I can pass about 90% of my clients on their first mailed PVSA. I use a standard of no sperm seen in 50 high-powered fields as my criteria. I also tell them at the time of the vasectomy that there's about a 10% chance that they won't be cleared on the first sample because I use a mailed specimen. But they do have over 99% chance of clearing eventually. So by telling them that up front, they really are less worried when they do get that if they get that first report that says that they're not clear of any sperm or clear of sperm. So if you don't already do your own PVSAs, I'm saying that maybe you should consider it. And the rest of the talk, I'm going to talk about how I do it in my clinic. basically every clinician knows what a sperm looks like under a microscope, and they know how to count. So all of us are perfectly capable of examining a post-vasectomy semen sample. Don't think that you're not. You're a doctor. You can do it. There are things other than sperm that are seen under a microscope, and it can be a little confusing: bacteria, epithelial cells, blood cells, debris, but those are ignored, and only the sperms are counted anyway. So the sperms do not need to be motile to be seen. Dead sperms are really just as visible as live ones. This spreadsheet was set up by David Sokol in 1993. It's very handy if you want to turn sperm per high-powered field into sperm per ml. But you need to know your drop size. You need to know your cover slip size. And you need to know the magnification that you use. So this is an example. I don't know how well you can see that, but the dropper on the left leaves a drop that is 50 microliters, and the drop on the right is 20 microliters. So if you want to convert sperm per high-powered field, you really need to know, per high-powered field to sperm per ml, you really need to know what size your drop is. And I use the 20 microliter drop. And then I put those figures, as well as the cover slip size and the magnification, into that spreadsheet, and it very handily converts. So one problem with using a larger drop, though, is it often exceeds the 22 millimeter cover slip, drips outside. So really, it's hard to use that Excel spreadsheet to convert, because you have some of the sample that drifts outside of the cover slip, and therefore the volume is wrong. But, you know, if you use the same size drop every time, you can just note the number of sperm seen per high-powered field in the patient's chart. That's why, it's consistent in your practice from one patient to another. And that same patient, if they have to repeat it, then if you just note how many high-power field you see, and you see a trend going down on subsequent samples, then you don't really have to bother with conversion to sperm per ml. So in the United States, with about $300 and a medical license, a CLIA waiver or certificate waiver can be obtained pretty easily to do provider-performed microscopy. The application is available. It's obtained at cms.gov, which is, of course, the federal. But the applications are always sent to your local state or your state Department of Health for approval. No proficiency or proof of competency is needed, because it's a waiver and not a certificate of compliance. Just remember, you're allowed to use a microscope on your patient to aid in the diagnosis and treatment of that patient. So this really isn't a lab test per se. I mean, think of it like this: you use a microscope to enhance your vision, just as you would use a stethoscope to enhance your hearing. It doesn't take any special licensing to use either. So here's a picture of my kit. This is what I send to patients. That moniker, verifyvas.com, is kind of in development. I don't have it available to anyone else because I'm not quite there yet, but maybe at some point somebody might be able to use this app. I was going to do the specimens myself, but because of the CLIA waiver restrictions on my own patients, I'm not able to do that. But it complies with postal code 101710 for handling exempt human specimens. Many years ago, I think maybe Doug does this, but I started handing out a small box with a vial in it to the patient at the time of the vasectomy, and then they would return at the right time, and it would cost over $4 in return postage. So recently, I came up with a kit that I could send by mail to the patient at the proper time using one forever stamp. So in the U.S., that's about $0.50, just 55 cents, and then another forever stamp for the patient to return it already on the envelope. Very convenient. As Jay said, the less difficult you make it for the patient, the higher compliance. We mail the kit to the patient 2 months after his vasectomy, so he can't really lose it in the meantime or forget it. It comes in the mailbox. It's there. He's going to have to make a conscious decision to discard it or to follow through and do the test. It's about the size of a greeting card when assembled. So here's a copy of the instructions that I send with it. They're detailed because, the fewer instructions, the more likely people are going to make errors. I added pictures a while back when I was having people kind of confused about things, and I've really had almost no errors in collection since I added some pictures to it. I've also developed a web app that I use to track when a kit is due to be sent, as well as the results. So when a patient appears in the queue, based on their vasectomy date, and I use 8 weeks because I like to clear people as soon as I can. I think it's patients like it too, especially when it's pretty easy to repeat. So at 8 weeks, they're in the top of the queue, labels are printed, and then the kit is shipped. And then if the sample does have any sperm, the patient goes back in the queue automatically. So if I put in a positive result, automatically go back in the queue. So a month later, they get another kit. The patient gets a report as soon as it's finalized. When I click that it's done, they get an email link, a secure email link. The test on the left is negative, positive test on the right. And when positive, you can see down the comments that the concentration is specified. That way I can see for myself what the trend is as I do more. And the patients can see that also. And each report tells the patient what to do next. That's really important too. I don't have to call them and tell them because the report already says, okay, you're all clear. You can rely on the vasectomy. Or it says, sorry, we saw some sperm. You have to wait for another repeat test kit. Now, if sperm are still seen after 6 months and 4 tests total, then they must submit a fresh specimen to see if there are motile ones in order to follow the AUA guidelines and perhaps clear some of those that have lingering non-motile sperm. So in summary, PVSAs do help reduce the risk of pregnancy after vasectomy and give patients peace of mind. Now, the numbers may not say it's a large amount, but if it's you and your family and you've been able to catch a vasectomy that didn't work earlier rather than later, I always tell my patients better to find it on a semen check rather than a pregnancy test on whether it failed. And patients are more compliant with PVSA submission when they don't have to transport the specimens. I believe that. I went from maybe around 50% compliance to 90%. And really the major thing I did was start mailing. There are outsourcing options that are available that allow patients to test themselves, such as the sperm check, or mail their specimens directly from their homes, but none are perfect. Primarily, they can't quantify the positive ones. And all vasectomy providers have or can develop the basic skills to do PVSAs. It's always been a basic part of me doing a vasectomy. It's hard for me to imagine using a lab, but I'm just my own little island here, in the middle of the United States in Indianapolis. Everybody's got their own training background and systems, but it's not impossible to set up your own system to get this done. I did it. Anybody else can. So if you really want to have more control over your PVSAs, be happier with reports and with compliance, then consider doing it yourself. So that's all I've got to say. Thank you for allowing me to be part of this. And if there's questions that pertain to this, we'll wait for Michelle to ask and moderate that. So Michelle, back to you.
Yes, thank you very much for this clear presentation, Don. Actually, we'll go on with the questions at the end. Already there are some answers that you provided for some questions that were sent by on the chat. Now let's introduce our next speaker. We'll go on the other side of the Atlantic now, and we're going to have the pleasure to have Dr. Melanie Atkinson, who will be our next presenter. She's a UK general practitioner, semi-retiring, but performing no scalpel vasectomy since 2001. She's currently a vasectomy surgeon and trainer for the Aneurin Bevan University Health Board in South Wales. She is also a vasectomy training leader for the UK Association of Surgeons in Primary Care, the ASPC. And of course, Melanie, I cannot ignore your new hobby, research on post-vasectomy semen analysis. So let's hear about it.
Hi, Michelle. Thank you very much for that. Let me just try and share my screen. Okay, can everybody see that okay? Right, so good afternoon, everybody from South Wales. It's getting on for about 4 o'clock here. I'm really pleased to have this opportunity to talk to you. I should mention before I start that I'm the principal investigator of the PVSA head-to-head study. Aculabs, the postal lab that we're using, are not charging us for testing the postal samples, but I have no financial interest whatsoever in this company, so there's no conflict of interest. So today I'm presenting a case study, 2 recent publications, and just giving you a little taster of our exciting new head-to-head study. So this is the case study. Bill Bloggs has just had a vasectomy and his surgeon gives him a choice of fresh or postal testing. He decides to go with postal testing because his brother Ben had his vasectomy with another surgeon and he's complaining about fresh testing. Ben had to ring for an appointment. The earliest one he could get was 20 weeks post-surgery. He'll need unpaid time off work, and the local lab is 50 minutes away. He reluctantly booked his appointment. Bill and Ben compare the kit they've been given. There doesn't seem to be much difference, except that Bill's kit contains some packaging to post the sample in his local post box. If they both submitted samples, this slide shows how they'd be tested. Apart from timing and temperature, testing is exactly the same, although different labs may use different slides to count sperm. So Bill puts his sample in the post at 16 weeks. That's quite a common time in the UK, more so than 12 probably at the moment. His sample contains more than 100,000 sperm per mil. He submits another postal sample at 20 weeks post-vasectomy. As this still shows sperm, a week later, Bill is advised that he requires repeat testing. It could be another postal sample, but he's advised that if he submits a fresh sample to the local lab, it's highly likely that he'll be given clearance to discontinue additional contraception. A fresh sample showed less than 100,000 non-motile sperm per mil. He was therefore given clearance with rare non-motile sperm, a preferred term to special clearance, and he stopped using additional contraception. Unfortunately, Ben did not attend for his appointment. The only possible outcomes from postal testing are either clearance or repeat. If sperm is seen on a postal sample, we do not know if they were motile at the time of production. So 0 sperm is the only number that we can currently give clearance on. However, when postal testing is used as part of a strategy in conjunction with fresh testing, as in the case above, it can provide a simple, cost-effective means of detecting all vasectomy outcomes. So the next step really is to gain evidence to validate this strategy and challenge the 2016 British Andrology Society guidelines, which do not currently recommend postal testing. So evidence for postal testing is currently limited to this one paper, which I published in 2021, along with Michelle and Gareth from the ASPC. This was a retrospective cohort analysis of data from over 70,000 vasectomies collected by the Association of Surgeons in Primary Care, actually over an 11-year period. Over 58,000 were eligible for analysis, 56% used a postal strategy, and just 44% used a fresh strategy. Data was stratified by number of tests and time, as in 2013, the UK Faculty of Sexual and Reproductive Health guidelines changed to single sample clearance and less than 100,000 non-motile sperm per mil cutoff for clearance with rare non-motile sperm. Overall compliance was more than 20% greater when a postal strategy was used. And following the current guidelines, 2014 onwards, was still significantly higher by 18.6%. Surgeons less commonly reported early failures with postal strategy in all strata, but the differences were smaller following current guidance, again post 2014, and that was no longer significant. When the higher compliance rate for postal strategy is taken into account, and a 1% early failure rate assumed for both postal and fresh strategies, you would expect to detect one more early failure per 500 vasectomies. Had postal strategy been missing early failures, we would have expected to see more late failures in the postal cohort, but that wasn't the case. So the PVSA head-to-head study is a direct comparison of sperm numbers detected in PVSA samples when the same sample is examined fresh in the local lab within an hour of production and following delivery to a postal lab by Royal Mail. Also, all samples showing sperm at fresh testing will be retested at the local lab on the same day that the postal portion is examined in the postal lab, that is 3 days later. Our hypothesis is that there will be no clinically significant difference in number of sperm detected when semen samples are examined fresh or after postage. So are we looking too hard to find sperm? Non-centrifuge samples are reliable at identifying samples with greater than 100,000 sperm per mil. Centrifugation is not recommended and may result in unnecessary repeat testing. We know that the current threshold for clearance on a postal sample is 0, but should it be? This study, can a low sperm concentration without assessing motility confirm vasectomy success, examined the likelihood of observing motile sperm according to the sperm concentration per mil. It found that however low the number of sperm detected, motile sperm can still be found, but that the risk is very low with very low sperm concentrations. This study looked at results from nearly 6,000 PVSA samples. The graph shows that the likelihood of motility increases exponentially with sperm concentration, the likelihood increasing dramatically beyond 1 million sperm per mil. This highlights the importance of the lab reporting the exact sperm count, even if motility cannot be assessed. So this study supports the current 0 threshold for clearance on a postal PVSA. It provides evidence for the use of sperm check vasectomy, a home test which tests positive for sperm concentrations above 250,000 per mil. There is just a 0.3% chance that there will be motile sperm present with 1 negative sperm check result. And they estimate that the likelihood of falsely concluding a vasectomy successful is virtually 0 with 2 negative sperm check results. The study suggests further postal testing for sperm concentrations below 1 million per mil, if preferred to the inconvenience of fresh testing. It also provides data to allow consideration of shared decision-making regarding further testing with very low sperm concentrations on postal testing. So in conclusion, development of strategies to make PVSA more acceptable to patients is a goal we should be working towards to promote compliance, reserving the less convenient fresh semen testing for when it is genuinely required to report upon motility.
Thank you so much, Melanie. Thank you for being with us. Yes, we look really forward to have the result of the head-to-head study. That's going to be tremendous new knowledge we're going to have for post-vasectomy semen analysis.
Thank you.
For the sake of time, we'll go on and have our next speaker, who's Mathieu Boilard. Dr. Boilard actually is not a real doctor. He's a real doctor. We're not. We're a physician. Dr. Boilard is a PhD in biology of reproduction. Dr. Boilard developed a technology that allows very precise measurement of sperm using flow cytometry analysis. In 2011, he founded Nessie Biologie Médicale in Montreal, in Canada, offering diverse semen sample analyses, including analysis of post-vasectomy semen sample. Is this a fashion or a revolution? Mathieu, everybody is curious to know more about your work and experience. Nous t'écoutons.
Thank you, Michelle. Thank you very much. Share my screen. You just confirm that everything works fine, all right?
Here we go.
All right, putting this into a slideshow version. And yeah, this is going to be a so hold on tight. So as far as conflict of interests, I'm really into it. Like, I'm the owner of a company, as Michelle discussed. My lab, as you see on the picture, is a flow cytometry lab, and we do a lot of flow cytometry analysis for fertility diagnostics, but we also do a post-vasectomy semen analysis using the system that you see on the right. We also accept research contracts for people who want us to help them develop their own flow cytometry testing, and we also run research projects that mostly are directed towards inventing new tests for fertility problems diagnosis. So the panel of analysis that we've developed is basically based on sperm scattering by flow cytometry. On the left panel, the panel A, you see events that are present in the semen sample displayed as per their size and their granulosity. So you can pretty much identify the sperm cells on this panel. They're the darker black dots that you see there. And if you intersect these granulosity and size parameters with the DNA content of the events that you see on panel B, the gate is identified as SPZ. So the DNA content that you see here, you intersect these three parameters, you pretty much are able to identify any sperm cell and discriminate them pretty efficiently from the rest of the events that are present inside the semen sample. By adding more dyes, you can identify other things like white blood cells, or you can also identify viability of these cells, including the viability of the spermatozoa. So this is the panel that we've developed back almost 12 years ago. And the next two slides are basically showing off the clinical performance of the test. So by, for example, using spike samples, you can basically add sperm cells to any tube and verify if the flow cytometer actually detects exactly what you've done to the tubes. And you see that the Pearson coefficient of correlation are like 0.99, and the coefficient of variation on these tests are pretty good in the range of 1,000 to 10,000 sperm cell per ml. So it basically says that the flow cytometer catches everything you're trying to do to mess him up, and you can't fool it. If you go in the range from 1,000 to 1 million sperm cell per ml, the Pearson coefficient of correlation increases to 0.999, which is basically the criteria for a clinical chemist to, label the method as the absolute count. So we had our reference method developed at that point, and we were pretty happy about it. We used the flow cytometer to do parallel analysis. So we would analyze the same sample by microscopy and using cytometry. And what we've learned is that almost all samples displaying zero concentration using the microscope actually contain spermatozoa. You see them on the very bottom line there, where there's zero concentration under the microscope. And some of them also contain living ones. So this was us performing microscopy and also doing cytometry on the very same samples. The microscope that we use is the one that we use to do fertility assessment. So it has, enhanced bright fields and all the fancy stuff to do good analysis. But still, we were not really able to be as good as the flow cytometer determining if there were sperm or living sperm in there. So this technique I just described to you is the PVCYT. We call it the PV cytometry. We have a baby version of that test, which is the PV48. What we do with PV48 is we don't assess for viability or leukocytes or epithelial cells or anything like that. We just count sperm cells per DNA content, sperm DNA content. So samples can be taken to any local service point. They are cooled upon arrival to protect DNA so that the test of detecting sperm cells in the tube can work. They're taken to our lab within a 48 hours period, hence the name PV48. It's extremely easy for the patient who can basically set up an appointment any time of the day, any day of the week. And with the service point, they just drop their sample there, and then they're taken to our lab for analysis. Because the flow cytometer has been allowing us to demonstrate that when samples show up at less than 5,000 sperm cells per ml, they don't contain living sperm cells to an extent that it could be dangerous for pregnancy. All spermatozoa concentration below 5,000 per ml are confirmed as vasectomy success. And we screen out roughly 80% of samples like that on the first test. Thousands of patients use it in the province of Quebec right now. We went from selling maybe a couple of hundreds of those a year to now I think we're going to be close to 4,000 this year. I wanted to present you a case report. One is from 10 years ago, one of the first one we've had. No spermatozoa were observed in a man that had been vasectomized in 2012, but unfortunately contraception was abandoned and spouse became pregnant after 3 months. What was challenging is that after the second traditional spermogram, that the one that followed pregnancy, results came back negative again. So now women became very angry at everybody, of course, and she knew she was faithful, and so the patient was referred by the doctor to our place, and we didn't see any spermatozoa under the microscope either, but the flow cytometer identified thousands of living sperm cells in the sample, and from there we just jumped back into the microscope and dig basically forever until we saw motile spermatozoa in the sample when we filmed them, because we were just at the beginning of using flow cytometry and we wanted the doctor to believe us. So once we've identified these living sperm cells and motile sperm cells, it kind of cleared the situation out. Second case was really recent one, concentration of 5,000 sperm cell per ml, 5,200 sperm cell per ml was detected by the flow cytometer. And the doctor was very meticulous sending back the patient to us because he was so close to making the cut, right? Because the cut is 5,000 per ml. He was just above it. So sending us another sample shows up at 5,500 on the second test. So everybody was a little bit discouraged, right? So the doctor was very meticulous again, sent us back the guy so we could test on a fresh sample. And in this case, again, we found thousands of living spermatozoas in his sample. So, reinforcing our decision that 5,000 should be a serious cutoff to consider if you really want to clear patients based on is there living spermatozoa in there or not. So just to make it a short presentation, I'm going to jump to conclusion right away, but we can talk further about that anytime you want. I'm very, easy to reach out to. So long story short, microscopy is still used by our lab. We just get a glimpse at every sample that we get. We want to have a look at what the sample is like. But the company is now using exclusively cytometry to determine sperm concentration in the samples. The clearance criteria of the PV48 is pretty severe, but it appears to be for good reason. And I think the number 2 case I've presented to you enlightens that. We like this technique because as clinical chemists and cell biologists, it puts a nail in the coffin. The quantitative quality controls that we operate as we perform the test leaves no doubt at all. And since we can define the clinical performance of the test on a very mathematical way, it is really the type of work that we like to do. We don't see any pregnancy or early recolonization. I think that the flow cytometer is so sensitive to find sperm cells that all these guys that will show up as early recolonization, even if they sometimes show with very few sperm cells that you might miss on the microscope, you can detect them on the flow. So we don't see these early recolonization situations. One case of late recolonization was brought to our attention very recently. after 6 years of clearance, but we don't have much details at this point. I didn't have the time to dig into that and see if it was a case of unfaithfulness or anything like that. I have to question the doctor about it, but fortunately at this point, I don't have the answer about to provide to you. So I'll leave it to that to make it short. But as I said, I'm really open to discussing with any of you, and thank you for having me today. I'm very pleased with that.
Thank you very, very much, Mathieu. So can you answer the question? Is it a fashion or a revolution? Probably if we look at your two-case scenario, doing our microscope with the post-vasectomy semen analysis with microscope, we probably have cleared a lot of patients. We still have living sperm, but pregnancy rate is probably very, very low even among those patients. So it's going to be nice to discuss these findings after the other presentation. So stay with us, and we'll go on. Our next presenter is Dr. Charles Monti, and like Dr. Snyder, he's also an obstetrician gynecologist by training, but vasectomy is his patient. He actively practiced no scalpel vasectomy, but also vasectomy and tubal ligation reversal in Raleigh in North Carolina. He's a dedicated supporter of No Scalpel Vasectomy International, like Jay, who has his nice sweater of No Scalpel Vasectomy International. He participated to mission in Kenya, Philippines, and Haiti. Dr. Muntin has often questioned the need for post-vasectomy semen analysis on the vasectomy network. Let's now see what he has to say about it in person. Charles.
Hello, everyone. Thank you, Michelle. Thank you, everyone, for allowing me to participate. Post-vasectomy semen analysis. Can we stop the madness? I feel like Alice in Wonderland. We're all mad here when we have these discussions. On the vasectomy network on Google, sometimes I think I have figured out the answer to the PVSA, and then we throw a little curveball. I oftentimes like to tell my patients, let's never order a test that does not change our management. And I have consistently been feeling like our post-vasectomy semen analysis are infrequently changing our management. A recent patient that I had, 42-year-old male, uncomplicated vasectomy, minimally invasive, intraluminal coagulation of the upper end, fascial interposition with clips. 4 months after vasectomy, non-motile sperm, too numerous to count. I don't see that often. We do our own analysis in our office. I had him come into the office, no granuloma, side-by-side ends of the vas deferens on each side. The procedure was uncomplicated. 7 months later, 633 approximately non-motile sperm in a fresh sample. 9 months later, less than 100,000 non-motile sperm in a fresh sample. So we cleared him with that one, but you have to ask the question, when these patients leave the office, what's really going through their mind? How confident are they in their procedure? Do their partners go on to get other methods like tubal ligation? What's really happening after we do this? I liked, as Jay pointed out, the post-vasectomy semen analysis is a screening test. A screening test is a test that determines the likelihood that members of a defined population have a particular disease. The predictive value depends on the prevalence of disease in the population. For this reason, it is necessary to be able to find the population to be tested so that the prevalence is high. So keep this concept of prevalence disease in your mind. You know, if you're just starting vasectomy and your skills are not that good, what is the prevalence of your disease? If you are having a difficult vasectomy, say someone with an undescended testicle, what is going to be the prevalence of your disease? If you're using an occlusive method that historically has been shown not to be as good as some of the others, what is the prevalence of your disease in the patients that you're seeing? A screening test is most helpful when the prevalence of disease in the population is high. Mammograms for older women, prostate-specific antigen for older men, colonoscopy for older patients. Why do we save these screening tests for older people? Because the prevalence of disease is higher. Why do we not do these on younger people? Because theoretically, the false positives are higher and it's going to lead to more unnecessary intervention. What is the prevalence of your disease in your population? Not to belabor this, we're all familiar with these statistics. Ligation and resection alone has been shown to be up to 13% occlusive failure rate. Michelle asked me to point out that occlusive failure rate is sometimes different than pregnancy. Occlusive failure rate is looking at sperm, which is what we're talking about. If you do divisional extended cautery, 0.6%. If you do open testicular end, mucosal cautery of the abdominal end, and fascial interposition, you also have a low failure rate. So as your experience increases, and if you use a better occlusion technique, then perhaps the prevalence of disease, whether you consider that sperm or pregnancy, in your patient population begins to decrease. Your screening test becomes even less helpful. Study of vasectomy in Nepal, most of us are familiar with this. They looked at semen samples well after the vasectomy was done, and they found a good number of pregnancies. They found a good number of sperm. And to me, interesting, 11 men who had azoospermia reported pregnancies for which contraception occurred greater than 3 months after the vasectomy. So this just kind of supports how ligation and resection alone is not the most optimal technique. It also illustrates to me is how you can do a test and it may not even predict what we're trying to prevent. I also would like to ask the question, if these were done well after vasectomy, if all these men had semen analysis done 3 months after their procedure.
Charles, could I interrupt 1 second?
Yes.
Did you want us to present your slides? Because we're not sure are you presenting slides? Or
Yeah, I'm sharing my screen, I thought.
You're not sharing, yeah.
I'm
sorry, I wasn't sure.
I apologize.
Everything you said was very understandable. Nonetheless, it didn't create a problem for me to follow. Just so you know, it's not too bad.
It's even better. We're listening to you.
Good. Can you see me now?
No.
No?
Yeah, now we can.
Apologies.
Yeah.
So,
Let's go where you were.
So the study in Nepal showed that basically the ligation and resection wasn't as great as we thought it could be. There were pregnancies, and even men that had azoospermia on their semen analysis had pregnancies. So to keep going, I use a map in my office. I have every patient put a pin in the map. The map on the left is just all of North Carolina. The map on the right is the city of Raleigh. That's just my thing. That's what I do. I do it because it gives patients confidence that I've done more than just one and have some experience. I also like to use the map to prove points to patients. Patients will ask me, what's the chance of failure? And I'll say with this method, if you give us a sample and there's no sperm, it could be as low as 0.05%. And some people just look at it, they understand it as a low number, but statistics don't always register with patients. So I'll oftentimes show them the map and say, none of these men have reported failure to me after 3 months. No one has caused pregnancy. And I think the visual interpretation just gives different meaning to these patients. When I do this, I oftentimes am asking myself, why am I doing this post-vasectomy semen analysis on all my patients? Why do I have to make 7,000 bags, 7,000 collection specimen containers? Why do we have to take all these office calls? Are we open today? What are our hours? That type of thing. And it's also important that I point out this is one doctor and one method. We send patients a survey 1 year after vasectomy, asking them many things, but one of the things we ask is, did you cause pregnancy? In our survey, we sent out about almost 5,000 surveys. We got a 45% response rate. 7 men said yes, they had caused pregnancy. We contacted these men. 3 said they clicked yes in error. 2 reported yes, but they didn't respond to our email. And when we looked in their records, they had negative semen samples at the 3-month check. 2 men reported pregnancy before they had the post-vasectomy semen analysis. In the 2 confirmed pregnancies, 1 reported clearly getting pregnant before 3 months. 1 had delayed clearance who reported pregnancy before 3 months. That person reported pregnancy right within 12 weeks of vasectomy. At 20 weeks after, they had 261 non-motile sperm. 60 weeks after, they had no sperm. So what is the disease? Is it occlusive failure or pregnancy? Can you get pregnant with dead sperm? What are the chances of pregnancy with small numbers of motile sperm? Why don't we focus on pregnancy? I would like to make the argument we should be focusing on pregnancy because that's why we do vasectomy. I understand why we don't focus on pregnancy because it is a rare outcome after vasectomy if you use a good occlusive technique. But, continuing to focus on sperm instead of pregnancy may not be very helpful. I would like to argue that as our skill increases, as we have better occlusive techniques, that sperm are now surrogate endpoints. A surrogate endpoint is an outcome measure, commonly a laboratory test, that substitutes for a clinical event of true importance. Surrogate endpoints in clinical research pose a real danger in the practice of medicine. A valid surrogate endpoint must both correlate with and accurately predict the outcome of interest. Clinical research should focus on outcomes that matter. I would like to make the argument that with better occlusive techniques, as our skill levels increase, looking at sperm is not an ideal thing to be doing. I would like to argue, let's stop the madness. Let's work on our vasectomy proficiency. Let's choose the best occlusive techniques we can use. Let's continue to make vasectomy easier for patients and reassure them that they are choosing the best method possible. Thanks for the group, and sorry not to be sharing.
On the web for a surrogate endpoint is an outcome measure, commonly a laboratory test that substitutes for a clinical event of true importance. Surrogate endpoints in clinical research.
Thank you.
Thank you very, very much, Charles. We have it's just bringing to us more point of views, and it's so interesting that we still don't have all the answer, but research is needed. And as you pointed out, we should probably focus on the most important endpoint, which is the pregnancy. And we will probably have times for discussion after the last presentation. Our last presenter is Happy Tairi Kampire, and she's from Kigali, Rwanda. And Happy is not a doctor, but one day she will be. She already detains a master's degree in global health delivery from the University of Global Health Equity in Rwanda. And she's currently a student in the PhD program in clinical epidemiology at Laval University in Quebec City. I have the chance to work with her. Her research interests include male engagement and shared decision-making in family planning. And incidentally, her PhD project focuses on decision-making related to post-vasectomy semen analysis. Happy, please tell us more about your work.
Thank you so much for the introduction, Michelle. This is a very good cue from the previous presentation. We're going to be exploring more on how we can support our patients to make better decisions or just to accompany them into the decision if they choose to do or not do a semen analysis post-their vasectomy. So I'll just start the presentation. So yes, so we will be looking briefly at the current compliance rate in North America and what exactly is influencing the compliance. Previous presenters have talked about it briefly, so I will just glance at it. And we will also present a clinical case and look at a possible solution, talking about maybe shared decision-making. Could it be a possible solution that we can explore to accompany our patients? And briefly on our study that we're doing in Quebec City. So as previous presenters have talked about, it is recommended it is recommended that patients do one semen analysis about 3 months post their vasectomy to confirm whether the procedure was successful or not. And from this, 95% will be declared sterile with a French sample, and 5% will be asked to redo the test. And from here, some will be asked to redo the vasectomy, or others will be declared sterile by 6 months. So occlusion failure or the need to redo the vasectomy is a rare event occurring in less than 0.5% of cases when an appropriate vasectomy occlusion technique is done. However, according to the American Urology Association, only about 55% to 71% perform at least one PVSA, and this is in typical clinical practices in North America. And here in Quebec, the two vasectomy clinics that we work with, they vasectomize about 4,500 men per year, and only 55% will submit at least one post-vasectomy semen analysis, which is very similar to what American Urology Association has reported. So for our clinical study, here is Mr. Tremblay. He's 35 years old. He's a truck driver and he has 4 children. He is remembering, this is 3 months after his vasectomy, so he is thinking, well, I was prescribed a semen test to do. What should I do? So these are all the ideas that are surrounding Mr. Tremblay's decision. He wants to be sure that his vasectomy worked, but the clinic or the lab that he can do his test is very far from his house. He did read online that the risk of failure was very low, and he's wondering if abortion could be an option if they ever experience an unplanned pregnancy. He definitely doesn't want to have more children, and the idea of masturbating at the clinic is a definite no-no for him. Could this be a difficult decision for Mr. Tremblay? Let's dig deeper and find out what other patients have said in other studies. So these are some of the reasons why other patients have taken a chance with that lurking sperm. So patients who do not comply with providing a semen analysis at the end have said that they trust their provider, that they trust the procedure, that everything went well, that they forgot, they're uncomfortable with masturbation at the clinic, that they don't have enough information. Sometimes there's no testing centers for them to provide their sample. Maybe abortion could be an option, and we would love to hear other reasons that people have reported in your clinical practice or in your maybe patients have shared with you. And when patients have complied, is because they want to be sure that the procedure worked. They want to know their fertility status, and an unplanned pregnancy could be a very big issue financially, physically, or to the well-being of their partners. So could this be a difficult decision for our patients? What exactly is a difficult decision? We call a decision difficult when several options exist. So different medical options exist for a medical condition. So in our case, patients have been deciding to do or not do the test. The outcomes of the options are uncertain. The pros and cons associated with each option are weighed differently. Our patients are clearly looking at either doing or not doing the test very, very differently. So according to the Ottawa Decision Support Framework, they suggest that in cases where patients are facing a difficult decision, different tools can be provided to them to help them make better decisions. So this can be clinical counseling, providing decisional tools, or decisional coaching. And the outcome of interest in this case would be for our patients to make informed decisions that are based on their personal values. So patients are given the most updated, evidence-based, and balanced information on the possible options when they have to make a healthcare decision in this case. So our study has been to create a decision aid tool. This is our decision aid tool that we introduced at Vasectomy Quebec. They have 2 clinics here in Quebec, and we present to them the risk of failure using exactly the information from the clinic. So we are presenting to them, if not information from other clinics, but like real information from how Vasectomy Quebec has been practicing. So we give them info on the risk of failure or success using graphic and text to really support the information and highlight it better. We give the information on where they can get their post-vasectomy semen analysis. We also provide reasons why they can choose to do or not do the test. And then this patient decision aid tool is given at the time of the vasectomy with the prescription of the semen analysis. We implemented our tool at Vasectomy Quebec in October 2022. So we're going to be collecting. I mean, we've been collecting data from patients that were vasectomized in August to September as our non-exposed group. So these people did not receive the patient decision aid, and then also interviewing people who were vasectomized after we introduced the tool. And we're going to be comparing the 2 groups. So we will do follow-ups at 4 and 6 months. And we will be evaluating measures such as the stage of decision making. So we want to know our patients, where exactly are they? Are they still thinking about it? Have they made their decision on whether to do or not do their test? The decisional conflict level, or the level of regret, and their expectations. Thank you so much. That's the end of my presentation.
Thank you very much, Happy. We look forward to have your result. Maybe next year in the next webinar, you can provide us with the result of this interesting study we're doing.
Happy to.
Actually, we thought that would be, with all the information we got from all the speakers, this is some sort of a achievement of all the reflections we had on post-vasectomy semen analysis, all sort of ID to increase compliance, to increase the accuracy of the post-vasectomy semen analysis. But in the end, we thought that the patient has the choice, and we're going to give them the tools so they make an informed decision. And this is why we did. And we're going to look at the compliance also at but the decision making and the comfort with the decision is the main outcome. Thank you very much. Now, we still have 200 people registered and there. I would probably take questions from the participant. We had many questions that were done during the webinar. Some were answered already with the presentation, but if you can raise your hand, you just go on the tool in your reaction and lift up your hand. We already have Esgar Gorin who will be asking a question.
Michelle, could I just intervene really quickly?
Of course.
I just wanted to, first of all, thank the translator who did an amazing job. I'm told she worked really hard. It's been an hour and a half, almost 2 hours of translating nonstop, a lot of technical terms. And so that she has to stop. It's just normal. So if you don't, you can join the English group and hopefully you'll understand. But thanks very much to the translator. Marta is her name, and did an awesome job. So I wanted to thank that. Second of all, I'm going to be just really quickly. We're again, like we've now we're going to put up on the side the form I had sent earlier, how you can contribute. You can give a donation. It'll be on the sidebar. I'll put it in the notes, and we put in the information where to send a check. We added that as per Doug's suggestion, so that will be on the chat box on the side. We really appreciate it. People can donate. And finally, I think there's going to be, at the end, Kati's going to put up some questions. There's going to be evaluation forms. And I wrote a little Father's Day letter to everybody that we'll be sending as a link as well. Just kind of summarizes the origins of World Vasectomy Day for those who don't know it. It all sort of started on a trip with Doug. Doug's there. But I'm going to pass it on because I know there's tons of questions. I just wanted to do that housekeeping. Thank you again, Marta, for the translation.
Yeah, thank you, Jonathan, for this important reminder. And donation is so important for the organization. And I'm sure with all the people here, even if everybody gets $1, we're going to have $200 more, $10, $2,000, and it would help in developing the activity all over the world. Thank you. Caddy already put the evaluation form on the chat. So please do that after the meeting. Please open the link and fill up the evaluation. So Isgar, and then Doug.
All right. Well, thank you so much. At the risk of sounding like NPR in the United States, I'm going to echo again the importance of donations. So if you have $1 million under your mattress and you don't know what to do with that, well, World Vasectomy, they will find a way to use it very appropriately. If it's $1, then do it too. So my question actually, and I don't know if we do have an answer about this, because I rely on all of my patients. I do a mail-in sample, and I put together a kit and kind of follow the guidance and that I got from Doug when I trained with him way back. But the problem, or what I don't think we discuss here, is what would be a good way to evaluate those samples. Yes, we talked about the inability to assess motility for obvious reasons, but we didn't talk about the other technicalities that actually make a good sample. You know, I have had these patients, I draw the line as I tell them at 5 days, 5 to 7 days, right? Because I don't want to have a sample packed with bacteria, you know, all clouded and fungi, and I see hyphae and yeast, and I don't want to see that. So I draw the line about 5 to 7 days, but I have had patients, I don't know what they do, because my sample, the bag that they send me has the date when they collected the sample. And I look at the postage, and there's a difference of 7 days in between both of them. Like, he collected the sample one day, and 7 days later, he takes it to the post office. So then there are samples that I don't even bother looking at, right? Because I have a difference of 14 days. So what would be good timing is the question, I guess, because we didn't get to talk about that for a male sample.
Okay, now maybe we can have some our presenters who would like to answer this question.
I'll be happy to jump in on this, since I've done mail-in samples for over 10 years, yeah, some of them come back and they're stinky and gross. I agree. I don't like it when they're old either. But even in those, I feel like I can see sperm in it. And to try to, I mean, one of the bottom lines with compliance appears to be this, it makes sense. The more hassle there is, the more rules there are. How many days? How many ejaculations? What's the timing? And where, do I have to stand on my head to masturbate, or can I use a, condom, or whatever? I mean, the less the guy has, less hoops to jump through, the more likely they are to comply. That's my opinion. I think some other people might share. So I keep it simple. I have them, when they get their kit, I tell them masturbate right away, whenever it's convenient. Once they prepared it, I have them put it in the freezer just overnight. What I feel like that does is it reduces the chance of the bacteria proliferating too soon. I mean, obviously it doesn't stay frozen the whole time. I tell them in the instructions that, but I think it delays spoilage a little bit. So that by the time it gets through the U.S. Postal Service, which sometimes is quite, rapid, other times it can take over a week. It's still okay. And yeah, I don't like it when they're nasty. I wish that I'd get none that were just smelly and awful, but once in a while it happens. But I still feel like I can read it. And so to me, that's kind of how I look at it.
Escar, I could comment on that.
Well, I agree. I've done what I've done with some patients is before the vasectomy, if they're willing to do that, because I no longer can use an alternative sample, I tell them to give me a sample, and what I do is I separate the sample in different vials, and I check them over time just to see how long I can go with that. And I have seen sperm, later, And I usually tell them, sperm doesn't disappear necessarily; it just is dead. But in terms of quality, just to standardize it, that's why I said that I draw the line, as I said, 5 to 7 days, because it's just to show them that there's a standard in what we're doing. I guess we don't have a clear answer of what will be appropriate. At the end of the day, we're looking at the absence of sperm rather than any other data. It's a qualitative sample. So perhaps reducing the friction will be, I wonder if we can give them the kit or the post-vasectomy semen sample kit with the postage already, so that all they have to do is just drop it in the mailbox. That will be helpful, right? And going back to what Don was saying, to reduce the friction, to reduce the hoops that they have to jump. That might be something that could help potentially.
Yeah, before we go back to Doug, probably Melanie has something to say about, have a comment about this, Melanie, or is it a question?
Yes, I have actually. Our postal lab, exactly the same as you. They go 5 to 7 days. Beyond that, they tend just to dispose of the samples. The postage is already included. So that I don't know if you saw the pack earlier in the slide, but the postage, they literally just have to produce the sample, walk to the post box, drop it in. We've had a problem recently in that we've had a mail strike. And currently, I think they're couriering the samples to get them there in time to make sure that they're within the 5 to 7 days. But literally, everything is there just for a walk to the post box, drop it in. It's got to be made so easy for them to get that increased compliance.
Very good. Thank you. Doug?
Yeah, we don't have a problem with contaminated semen specimens, because when we prepare our little tubes, we take a capsule of doxycycline powder and we pour it into the tube. And then we take that tube and pour that into the next tube, thereby leaving a little dusting of doxycycline powder on each tube. We never have a problem with samples that are overgrown with bacteria or hyphae or anything else. In addition to that, we've taken our mailed in reversal samples. Let's say that a person has a reversal and he has 100 sperm per high powered field, and we're happy with that. We let him know, yes, you got sperm back. We have taken those samples and put them aside. We actually taped them to the wall with the date on it. And we take a little aliquot of that sample every week for 6 weeks, and it looks the same. They're all dead sperm, but it's always the same number of sperm per high-powered field over a period of 6 weeks. So we don't really care, excuse me, if the patient mailed his semen specimen in and it arrived at our office on the Monday of a week that was off and it sat around for a week. We still feel that that's a legitimate sample for evaluation, because in samples for whom we know the sperm count, that sperm count has not significantly changed over a 6-week reevaluation period. The other thing that I would add, and it was the question I had for Don, is that when we put those little tubes in bubble envelopes, the postal lady got mad at us and said, this is human tissue / fluid. This must be transported in a box. So I love Don's idea of a forever stamp being adequate, because we spend $4.80 to mail them a mailer. We do not put the postage on the mailer for the patient because they lose them too frequently. We simply tell them to put $4.80 on the box to send it back. In other words, if we mail out a mailer, we collapse the flat box and put that into an envelope, but it's too thick to be read by postal machines. So the post office, the rate of postage is $4.80. So I would caution Don that you could be possibly out of compliance with United States Postal Service regulations on the transport of human fluid?
Well, I referenced it. It's 10.17.10. I talked to my postman, and he talked to his the local postmaster at our place. And if you read the regulation, it does not use the word box. It says a rigid container. My card is rigid. Now, some people think a greeting card's rigid. Others think it's not. But rigid isn't a box. And so I've never had a problem with the post office saying that we can't do it.
10.17.10 is part of the United States Postal Code?
Yes.
Thank you.
Very good. Thank you very much, Doug. You should publish those results. It would really help Melanie's point about her study. So please do so. Doug, you have so many papers to publish. So thank you. Matthew, you had a question. I think Chick had a question also, but Matthew raised his hand. So Matthew?
Yeah, it's not a question, actually. It's a remark. I had never realized that it was a subject that was discussed among your group, whether or not sperm cells could like disappear by being transported somehow. But cells don't disappear like that, especially sperm cells, because they're highly fibrous, like they're made of actin, and there's a fibrous shed inside the flagellum, and all these proteins won't just, digest themselves, out of nowhere. So it doesn't make sense that these cells will disappear. They will not, unless they're just eaten by some active leukocyte activity or something like that could digest them. You could lose them if, as previously mentioned, there's a lot of bacterial contamination that makes it like a pudding, and you don't see anything. I'm thinking that maybe if some of you guys are working with postal samples, you could have a company produce tubes that are the collecting tube or the transport tube into which the patient could pour the sample into, and have the tube that is meant to be mailed pre-coated with some sort of antibiotic like gentamicin or something like that. And that would probably, clear the field for bacterial growth. There are many companies out there that could, lay some sort of lyophilized antibiotic inside the tube for the transport, and that would probably help down the line. But yeah, you don't have to worry about sperm cells disappearing because they're being digested or anything like that. You'll lose them different ways by performing microscopic evaluations, but it's not because they're just not there. They're still there.
Okay.
I hope
very interesting. This is very interesting, Matthew, and you should share publication of that with Melanie, because probably I will tell the comment, Melanie, but in UK, the andrologists are saying that sperm are disappearing if they get on, and this is why the head-to-head study has been started in UK.
One thing that could happen though is that if the tube is being shaken and moved from one place to the other, sperm cells stick to one another with time, right? So they could agglutinate, and then you don't have an even distribution of them, mm-hmm. and it becomes tougher to find some unless you're very lucky and actually jump onto the agglomeration of all these cells. But they're not an homogeneous sample anymore across time. So it makes it more difficult for you to spot them if they're rare enough. So that might be one of the reasons why you see that. It's when you play with a lot of sperm samples in your career, you kind of learn these things. They're still there, but they're just fooling you.
Okay. Thank you. Chick, do you have a comment or a question?
Yes, thank you, Michelle. I love what Doug said, and I love his study. And I just want to emphasize that years ago I set all my samples on a shelf in the office, room temperature, and read them repeatedly over over days and weeks. And until a sample became overgrown with bacteria, the sperm count was identical time after time. And to Matthew's point, from Matthew's point, the sperms don't tend to agglutinate with each other. They agglutinate with the bacteria or the leukocytes. And then you definitely have the clumping effect that changes the concentration. But I love Doug's point, and I just want to make a plea that you don't throw away a patient specimen simply because of age. It doesn't matter how old it is. Take it out and read it, please. You can give that patient assurance that he's clear, or you can give him a warning that he's got too many sperm. Please never throw away a patient specimen. He's gone to a lot of effort, so to speak, to bring it to you.
Thank you, Chick, for this precision. Melanie, you had another comment?
Yes, I just wanted to comment on what Matthew had said. This agglutination that you're saying that may occur due to friction during transport, that hopefully that's something that we might be able to pick up with our study. It's going to make something to bear in mind. So, do you have any papers or anything on this that you can share, please?
It's just common knowledge for people who are in the andrology field, and if you've performed like IVF on bovine or ram, or if you've played with mice sperm cells, and you try to do experiments and you go like, oh, where are they now? And I don't think that anyone has ever published, how much sperm cell can you lose from your side by agglutination, but it's kind of common knowledge for lab people. You just lose them somehow. Sometimes they stick to the walls of the tubes. They agglutinate, as Chick mentioned, with bacterias or with leukocytes and amongst one another. And some patients will display more of that than others. And yeah, it's basically chaos out there sometimes. But I was just trying to explain to you that the chemistry of it, like you don't unless there's some enzymes that are involved, you will not digest a sperm cell. It will still be there somehow. And if you don't see it, well, it's not because it's been disappearing. It's just because you don't see it, period. You could freeze it and then thaw it and it would still be there. It's, you don't destroy such complex and solid proteins just by transporting them. It doesn't make sense chemically,
Great, thank you. Thanks very much.
Do we have more questions, or we've been together? Oops, sorry. Someone is talking anyway. If we don't have any question, I'm going to have another one.
She's raising her hand, but she hasn't learned you could ask Sarah Miller.
Sarah, yeah.
Sorry, I cannot find the button to put the virtual hand raised. So I have actual hand.
Just go on, Sarah. Ask your question.
Sorry, I this has been very informative. I love this discussion and I love that we're there. On the rare times when we do mostly, we offer a lot of it, but we do mostly in clinic follow-up PVSAs on mostly fresh samples, although sometimes people don't read instructions and bring them in after they've had them in their pockets for days or whatever. We also have found our numbers are very high. Now I know why. We make follow-up appointments and give them appointments in time, and we're very flexible, but people can come in at any point, and our follow-up rate is over 80%, which I think is phenomenal. People come from far away, which is, I also I just am, and I'm like picturing the lines in the post offices near me, and certainly driving an hour to my office and being in and out in 3 minutes is certainly easier than going to your local post office, just as an aside where I am. But my question is about what you do and how to have these shared decision-making conversations with patients when they come back, where our CLIA waiver doesn't allow us to say the number. So we know when we're looking at fresh samples and we see non-modal sperm, we know very confidently if there's just a few of them scattered here and there, that's fine. We know if there's lots of them, that's not fine. We've gotten over the years, not that infrequently samples where there's like 1 to 3 non-modal sperm per 400 high-powered field, and it's well over the threshold of what would be 100,000. I've had people come back. It seems like mostly these are men who ejaculate very infrequently, but I would love to hear people's theories as to why that would happen and how much we actually have to worry about that, and how to do that counseling with our patients to make sure decision makings of, do they have to keep coming back? Should they keep coming back? At what point you say it's okay that you still have these lingering non-modal sperm above threshold?
Yeah, this is interesting, Sarah, because there's been some studies way back about 40 years ago, and looking at the anatomy of people. We know that, first of all, if you're older, the clearance will take longer than if a younger guy. Probably it's the pressure of the ejaculation, but the anatomy of all those complex labyrinth formation in the seminal vesicle is different from one person to the other. We don't have the same size of the nose, so the men don't have the same size of the vesicle, seminal vesicle. So that probably explains why some people, even with the same number of ejaculation, it takes longer to go. And it's just a matter of having a cutoff. The 100,000 cutoff is based on expert opinion, and most studies were done with this cutoff. But I'm pretty sure that the 2,500 of sperm check is probably exactly the same. We're not talking, when you get the real recanalization, you don't get, sometimes you get 100,000 or 250, but most of the time you're going to get millions of sperm, like 10 millions, 20 millions. And that's what we want to catch. Probably the risk of those guys with very, very small number, the risk of pregnancy, as Melanie showed and Charles discussed about, is probably very low. So it's just a matter of judgment at that point. That answering your question? I mean, that's what we got.
Michelle.
Yes.
Michelle, something about this disappearing sperms and coagulation. I can show you. I can quickly share picture of coagulation, and this is a dynamic process. So after a couple of days, it is growing and growing. So I will try to approach my computer to this field, and I show you.
Wow.
Yeah. Can you see something? One moment.
Has to be closer.
Okay, so this is the there are parts of sperms that are approaching each other.
Yeah.
Maybe at the beginning it was better seeing. That's another.
Hey,
yeah.
Robert, you can share a screen.
Yeah, here. Yeah, no, it's not on my computer. I have to go to the sperm analysis computer, another. So that's the part of the sperms that are coagulating. So after a couple of days, it's more and more. So this sent by post sample, they disappear because after we mix it, after we make it more liquid, so those we can count only those free, but those groups are not free already. So that could explain this phenomenon.
Yeah, but thank you very much. That's very clear, and that's interesting.
I measured thousands I performed thousands of sperm analysis.
Okay. But we'll see now with the UK study. We'll see in a controlled manner what's the proportion of the sperm we're going to be able to catch with our cutoff. Thank you very much. We have a question from Kiza Blair. He's been waiting. Kiza, would you want to unmute your computer and ask your question or comment?
Thank you so much. I'm called Kiza Blair, as my name is. I am a medical doctor from Uganda. I've been part of this webinar series for quite some bit of time. And today I've been more than humbled and privileged to listen to various experts when it comes to post-vasectomy sperm analysis. So I just wanted to pass on a message from the different medical students that attended from Africa. I helped out in terms of mobilizing from Rwanda, from Kenya, from Tanzania, and I followed through up to the very end of the session. The only challenge they had is that we're utilizing on-campus space, and when it tends to get in the evening time, they have to close the campus. It's a weekend. But they enjoyed so much the session. They've learned a lot. I've seen a series of questions coming through the comment section. And I'm more than happy for such opportunities where medical students can get to learn about vasectomy as early as med school. Thank you so much.
Thank you for attending. And we hope we're going to have more. And actually, we had some questions from African students or doctors about semen analysis and the availability of semen analysis in country where it's not really available. And this is why it's so important. And many of the speakers have been talking about the importance of having a very good occlusion technique. So if the occlusion technique is very effective, probably the need for semen analysis may be less important than it is actually with the availability. So thank you very much for your comment. Mathieu, do you have a comment? And then we have another question.
Yeah, I just wanted to follow through with what Sarah brought on the table. We see a lot of men at NACI that showed up with very high numbers of sperm, like over 100,000 per ml, but they're all dead. We measure them by flow cytometry, and like the count of sperm is incredibly high, and the count of living sperm cell is 0. Okay, no matter how long we run the analysis, we could, like in these analyses, we roughly do the equivalent like of a 1,000 microscopic evaluations in 5 minutes, and the count comes down to 0. So they are out there, you know, and I agree with what you're saying is that it's not because your count is over 100,000 per ml that necessarily your vasectomy failed. I don't think it makes sense. So, yeah.
Okay, thank you. Joshua? Yep. His hand is raised.
Good morning. Thank you so much for this presentation. So we're pretty new to this PVSA stuff. So my question is about the technique. Is there any benefit to the technique of collecting the semen sample? Specifically, the lab that we're contracting with specifically recommend that people abstain from ejaculation 3 to 7 days before giving a specimen. And then the other question was that they said to avoid lube, saliva, and lotion. I did notice on one of the slides for the male in PVSA that it did recommend that only water-based lubes be used. And I was wondering how that affected it and what the recommendations are.
Yeah, maybe Mathieu or Don can answer this question.
Yeah, I think I can. I mean, because I use mail-in specimens and because bacterial overgrowth is a concern just for making it, if nothing else, nasty to read, but you know, it adds to the difficulty if there's more bacteria in there and all that. So I ask my patients not to. I ask them to masturbate to produce it, and so I just put on there that vaginal fluids and saliva can interfere with the results. I leave it that way. So you know, basically, I say don't do it that way because it interferes with the results. Well, it kind of can because it can cause bacterial overgrowth. That's basically why I do that. I don't think that the water-based lube will, and to leave them no options, then tell, you know, if I just say don't produce your specimen by having vaginal or oral sex is basically what I'm asking them not to do. I got to give them a little bit of an option. Well, how do we get this done without, you know, comfortably? So I say water-based lubes. I can't give you a study. It just makes sense to me to do it that way.
Yeah, it's pretty important that you don't get too much of that into the tube though, because they'll produce like big, you know, spots on the microscope slides where, you know, because that doesn't mix very well with the seminal plasma, and it removes some room for your analysis. Like you see these big droplets everywhere, and I would suggest that if they have to use it, because this is what we do in fertility cases sometimes, we just tell them, yeah, use them, but the bare minimum, so you're comfortable. But if you end up with that onto your slide, it'll ruin the analysis somehow.
I mean, most of these samples are so scant that I can't imagine there's anything additional to it. I mean, it's amazing how small of an amount a lot of people do supply. And there's a lot of spillage, but to Michelle's point, age has to do with volume and other things. But so anyway, having done thousands, I just haven't seen that as a clinical problem yet. But but again, it's not up to I'm not using maybe good study criteria data.
And
okay, I think it's time to close our session. Actually, we've been online since more than 2 hours. It's been very interesting, very nice talks. You understand that there are still some questions. We don't have the answers of everything, but that's not the sake of science. I mean, probably if we do this in 10 years or 20 years, we're going to have a different discourse. And there is still 126 persons still on. Actually, it's a record. Very interesting. I think there's a lot of enthusiasm to those sessions. So I remind you, please fill up the evaluation form. You have all the links that we're giving. Probably, Catherine, you can just put it again for the people who are remaining here, so you can go through all the messages. If there are burning questions, you can ask on the Vasectomy Network. If some of the people that just heard about the Vasectomy Network and they want to sign in, just send us some messages. We'll go on. And thank you so much, everybody, to being in here today. And we'll see you in a few more months for another exciting event.
And one final point for everybody. Thanks for everybody showing up. Amazing turnout. Final note is that you will be receiving the recording of this session, so everybody will get that if you do as you choose. But happy to do that. It'll be available, sent to you directly, and it'll be on the website as well. And everybody have a fantastic Father's Day. And enjoy everybody. And I always remind people, hey, we're all about fatherhood, not just about not being fathers, but so everybody out there, happy Father's Day, and thanks again for showing up.
Yeah, thank you very much. Just a last comment. How do people will get the attendance certificate? Are we sending it to everybody, Jonathan?
Everybody, I think we're sending out. Kathy knows she's sending out the little questionnaire to everybody who's going to be registered or attended, and I think it's going to be very easy. There'll be 3 to 5 questions, and then we'll generate that. That should come pretty quickly, but Kathy will know the details.
Very good. Okay, thank you so much.